All right, class, we're in our final chapter. We've saved the best for last, a little bit confusing part of the physiology of the kidney. And your lab that will be due on the 30th, which maybe you've already done already, I'm hoping this Labster lab helps kind of give you a visual representation of some of the physiology of the kidney as well. This chapter is divided into two parts. The first half of part A goes through the anatomy of the kidney, and we're going to pick up kind of in the middle of that first part where we talk about the physiology of the kidney. We'll keep it pretty simple, and I'll try to stick to the basic points that I want you guys to know about the physiology of the kidney, but we'll use both parts A and B for this as well. So your physiology of your kidney, the function of your kidney is to filter all the blood in the body. About 180 liters of fluid is processed daily, but only about 1.5 liters of urine is formed a day. The kidneys filter the body's entire plasma volume about 60 times a day. It consumes about 20 to 25% of the oxygen at rest, and the filtrate that is produced from glomerular filtration in the glomerulus is basically your blood plasma minus proteins. So urine will be produced from that filtrate, and urine is less than 1% of the original filtrate that gets filtered through. Your urine will contain metabolic wastes and any other unneeded substances. There's 3 main processes involved in urine formation and the adjustment of blood composition. And this is what I want you guys to focus on, these 3 processes, which we'll go over a little bit in detail. But for your sake, I just want you to know really well what they are. Glomerular filtration, which produces cell and protein-free filtrate. Tubular reabsorption, which selectively returns about 99% of the substances from the filtrate back into the blood in the renal tubules and the collecting ducts, and tubular secretion, which selectively moves substances from the blood back to the filtrate in the renal tubules and the collecting ducts. Here are the 3 major renal processes and where they occur. So here we have the cortical radiate artery leading into the afferent arteriole, which brings blood into the glomerulus. The glomerular capsule captures all the filtrate that's going through the glomerular filtration step. The efferent arteriole then carries the blood back out of the glomerulus into the peritubular capillary, back into the cortical radiant vein. Within the tubular system then of the kidney, we have tubular reabsorption happening, where the blood is reabsorbing about 99% of the filtrate back into the blood, as well as tubular secretion, so adding a few more things into the filtrate that will eventually form the urine. So glomerular filtration is a passive process. No metabolic energy is required for this. We have hydrostatic pressure forces, which are forcing fluid and solutes through the filtration membrane into the glomerular capsule, and no reabsorption into the capillaries of the glomerulus occurs at this step. The filtration membrane is very important. It's a porous membrane between the blood and the interior of the glomerular capsule. It allows water and solutes smaller than plasma proteins to pass, and normally no cells can pass. So normally you should not find any blood in the urine because red blood cells are not small enough to pass through this filtration membrane. It consists of 3 layers: a fenestrated endothelium layer of glomerular capillaries, a basement membrane layer, and then these foot processes of podocytes. So we have these, and I'll show you a picture of this. There's filtration slits that are made between the foots processes of these podocyte cells, and these slit diagrams will repel macromolecules. So this is a look at the filtration membrane. Here we have the afferent arteriole bringing blood in, the efferent arteriole bringing blood out, and we're going to zoom in here on this filtration membrane. The filtration membrane itself is made up of these podocytes, which are cell bodies, and then their cytoplasmic extensions of the podocytes make these little foot-like processes, and the filtration slits allow substances to pass through, as well as in the fenestrations themselves. The glomerular capillary shows the endothelium with the fenestration pores, which are holes within that glomerular capillary endothelium, as well as the filtration slits between the fluid processes. So we make this filtration membrane kind of barrier that only allows certain things through. This is a look at a photomicrograph showing the foot processes extending out from the branches of the podocyte cell body. The filtration slits are the spaces between the foot processes themselves. So again, it's always fun to see a real life picture of it instead of just a drawing. So here's another great look at the filtration membrane. It separates the blood in the glomerular capillaries from the filtrate in the glomerular capsule, and it has 3 layers: the capillary endothelium layer, the basement membrane layer, and then the foot processes of the podocyte, the glomerular capsule. And you can see here the blood in the glomerular capillary and how the plasma can go through. Macromolecules will get stuck in the filtration membrane and they're engulfed by glomerular mesangial cells. This will allow molecules only smaller than 3 nanometers to pass. So only water, glucose, amino acids, and nitrogenous waste can get through. Plasma proteins will remain in the blood to maintain a colloid osmotic pressure to help prevent the loss of all water to the capsular space and to prevent proteins in the filtrate will indicate a membrane problem. So you don't want proteins to get through, you don't want red blood cells to get through. That signifies that there's a problem in the membrane itself. Here are pressures that affect filtration. You have outward pressures that promote filtration, inward pressures, hydrostatic pressures, net filtration pressures is the sum of all pressures. Basically, what I just want you guys to look here is we have pressures coming from the glomerular capillaries, outward pressure coming back in, hydrostatic pressure, but overall we get a net filtration pressure of 10 millimeters out after we kind of add in all these pressures working against each other. The glomerular filtration rate is the volume of filtrate formed per minute by both the kidneys. Normally it's about 120 to 125 millimeters. The glomerular filtration rate is proportional to the net filtration pressure, the total surface area available for filtration, and the filtration membrane permeability. Regulation of glomerular filtration, it's very important as it allows the kidneys to make the filtrate and maintain extracellular homeostasis. The glomerular filtration rate affects your blood pressure as well. So an increased GFR will increase your urine output, which will lower blood pressure and vice versa. So we have extrinsic controls that help to maintain the systemic blood pressure. The nervous system and endocrine mechanisms are the main extrinsic controls. We have intrinsic controls, which are due to renal autoregulation. We have myogenic mechanisms and tuboglomerular feedback mechanisms. The myogenic mechanisms is just the local smooth muscle contracting to controlling glomerular filtration rate. And then the tuboglomerular feedback mechanism, this mechanism is directed by the macula densa cells, which respond to the filtrate sodium chloride concentration. If GFR increases, the filtrate flow rate will increase to lead to a decreased reabsorption time, causing high sodium chloride levels in the filtrate. And this feedback mechanism causes constriction of the afferent arteriole, which will try to lower that NFP and GFR. We have neural and hormonal mechanisms to also control the glomerular filtration rate. It's under the sympathetic nervous system. Under normal conditions at rest, the renal blood vessels are dilated and renal autoregulation mechanisms will prevail. So between the sympathetic and hormonal mechanisms, I won't ask you guys too many specifics about that, but I do want to mention briefly the renin, angiotensin, aldosterone mechanism. This is your body's main mechanism for increasing blood pressure in terms of emergency situation. If your blood pressure drops, if you lose a lot of blood, there's 3 pathways to renin release by granular cells: direct stimulation of granular cells by the sympathetic nervous system, the stimulation by activated macula densa cells. When it picks up that your filtrate sodium chloride concentration is low, and reduced stretch of the granular cells. So anytime systemic blood pressure drops, the decrease in blood pressure in the afferent arteriole causes a decrease in GFR. This decreased stretch of smooth muscles causes vasodilation to try to increase GFR. The decrease in glomerular filtration rate causes decreased filtrate flow and decreased sodium chloride. This acts on the macula densa cells of the juxtaglomerular complex of the kidney to release vasoactive chemicals and inhibit them to try to vasodilate the afferent arterioles as well. Then we have granular cells of the juxtaglomerular complex of the kidney releasing renin, which will catalyze a cascade resulting in the formation of angiotensin 2. Angiotensin 2 increases aldosterone secretion by your adrenal cortex, which increases sodium reabsorption, and water will follow to try to increase blood volume. Angiotensin 2 also causes vasoconstriction of the systemic arterioles, which increases peripheral distance, also increasing systemic blood pressure. And then the neural controls are just trying to increase the sympathetic nervous system. Here's some other factors affecting GFR, but this is probably a great summary of regulation of the glomerular filtration rate, the purpose of all the intrinsic controls, and then the extrinsic controls. Anuria is abnormally low urine output. So this is another one of our clinical imbalances that we talked about. So anything less than 50 millimeters per day, it may indicate that the glomerular blood pressure is too low to cause filtration. Renal failure and anuria can also result from situations in which your nephrons stop functioning, like acute nephritis, transfusion reaction, and any sort of crush or crash injury. So with that, we're going to go on to part B. Part B, we're going to try to keep really simple because there's going to be a lot of important things to look at in part B. But because we're kind of at the end of the semester, you guys have a lot to study already, we're going to try to keep things pretty simple. So we're still in the physiology of the neuron. Step 1 was glomerular filtration. Step 2 of urine formation is the tubular reabsorption step. Tubular reabsorption quickly reclaims most of the tubular contents and returns them to the blood. And we're talking about 99%. We have a selective transepithelial process where almost all organic nutrients are reabsorbed. Water and ion reabsorption is hormonally regulated and adjusted. This includes active and passive tubular reabsorption, and substances can follow either a transcellular route or a paracellular route. So this is the point at where we're talking about right now. Tubular reabsorption, about 99% of the contents of the filtrate will be reabsorbed back into the blood. The transcellular route is where solute enters the apical membrane of tubular cells and travels through the cytosol and then exits out the basolateral membrane. The paracellular route is just substances traveling between tubule cells. It's limited by tight junctions, but leaky in the proximal nephron. So water, calcium, magnesium, potassium, and some sodium in the proximal convoluted tube can move via this route. So this just shows how some things, water and solutes, travel the transcellular route through the cells, and some travel the paracellular route between cells. All right, and you can read through those steps there. Sodium transport, it's the most abundant cation in the filtrate, and the transport of sodium across the membrane is via primary active transport. So we need ATP to work our sodium-potassium pump to bump sodium into the interstitial space, and then sodium is then swept by bulk flow into the peritubular capillaries. So this kind of takes you through sodium being transported primarily by active transport, but this provides energy and means for reabsorbing almost every other substance. So then we get to this secondary active transport, which is the electrochemical gradient created by the pumps that give the push needed for the transport of other solutes. So organic nutrients reabsorbed by secondary active transport and are co-transported, so transported at the same time as sodium, are glucose, your amino acids, some ions, and vitamins. The passive reabsorption of water, so movement of sodium and other solutes creates what we call an osmotic gradient. So then water will be reabsorbed by osmosis. If you remember that water always travels into air to an area of higher solute concentration. So if we're reabsorbing sodium and all the other solutes back into the bloodstream, water will naturally follow. It's aided by water-filled aquaporins. They're always present in the proximal convoluted tubule, and they can be inserted in the collecting ducts if antidiuretic hormone is present as well. So here's your passive tubular reabsorption of solutes. The solute concentration in the filtrate increases as water is reabsorbed. So we have a solute concentration that drives their entry. Fat-soluble substances, some ions in urea will follow water into the peritubular capillaries down their concentration gradients. And for this reason, lipid-soluble drugs and environmental pollutants are reabsorbed, even though it's obviously not desirable for your body. So we have sodium being actively transported, water and other solutes being passively transported back into the peritubular capillaries, which will surround the proximal, kind of the loop of Henle. So with that, transport maximum, the transcellular transport systems are specific and limited. We have a transport maximum that exists for almost every reabsorbed substance. So when the carriers for a solute are saturated, there's always an excess that is excreted in urine. So if you are hyperglycemic with very high blood glucose, if you can't reabsorb the glucose back into the bloodstream, glucose will spill over into the urine. So as we talk about the reabsorptive capabilities of the renal tubules and collecting ducts, in the proximal convoluted tubule, this is the site of most reabsorption. So all nutrients, glucose, amino acids are reabsorbed here. About 65% of sodium and water is reabsorbed, most ions, almost all of their uric acid, and about half of urea, which will actually be later secreted back into the filtrate. Then in our nephron loop, we have a descending limb where water can still continue to leave, but solutes cannot, and the ascending limb where water cannot leave and solutes can. There's a thin and thick segment that's passive to different sodiums as well. Then we get to the distal convoluted tubule and the collecting duct. Reabsorption is hormonally regulated in these areas. So antidiuretic hormone, which is released by your posterior pituitary gland, causes the principal cells of the collecting duct to insert extra aquaporins, which increases water reabsorption in the distal convoluted tubule. So an increased ADH level causes an increase in water reabsorption, which will result in much more concentrated urine. Aldosterone is another hormone that targets the collecting ducts and the distal convoluted tubule. It promotes the synthesis of sodium-potassium channels and ATPases for sodium reabsorption, and water will follow. So as a result, little sodium will leave the body because most of it is also reabsorbed. Without aldosterone, you have a daily loss of filtered sodium, about 2%, which is incompatible with life. So we need aldosterone to reabsorb sodium. The functions of aldosterone are to increase blood pressure and increase blood pressure and decrease potassium levels. Then we have atrial natriuretic peptide. It's released by your cardiac cells if your blood volume or pressure is elevated. It reduces blood sodium, resulting in decreased blood volume and blood pressure. And then we have parathyroid hormone that acts on the distal convoluted tubule to increase calcium reabsorption. So here's a summary of the tubular reabsorption and secretion and different substances that are absorbed and secreted throughout the tubular system. Here's another good summary of the tubule segment, the substances reabsorbed, and the mechanism. And this is probably a great couple slide to study before we'll talk about part 3, which is tubular secretion. So tubular secretion, again, these are 3 steps in forming urine. The tubular secretion is the reabsorption in reverse. So tubular secretion are things going back into the filtrate. This occurs almost completely in the proximal convoluted tubule. Selected substances are moved from the peritubular capillaries through the tubular cells out into the filtrate. So we have potassium, hydrogen ions, ammonia, creatinine, and organic acids and bases. Substances synthesized in the tubule cells are also secreted. So again, this is where we're at right now. We're in the third step of urine formation, tubular secretion. Tubular secretion is important for disposing of substances like drugs or metabolites that are bound to plasma proteins, eliminating undesirable substances that were passively reabsorbed in the absorption step, like urea and uric acid, ridding the body of excess potassium. This is the aldosterone effect, and also controlling blood pH levels by altering the amounts of hydrogen and bicarbonate ion in the urine. One main function of your kidneys is to make any adjustment needed to maintain body fluid osmotic concentration. In the next slides, we'll go through that. Kidneys produce only small amounts of urine if the body is dehydrated, or dilute urine if it's overhydrated, and it accomplishes this using a countercurrent mechanisms where fluid flows in opposite directions in two adjacent segments of the same tube. You guys don't need to know about this, but this takes you through osmotic gradients and the countercurrent mechanisms of the kidneys. And I won't ask you guys to know this, so I'm going to jump ahead. And it kind of focuses a lot on this, so you guys can skip over this part, the countercurrent exchanges. It explains how to form dilute or concentrated urine and what happens in each segment of the tubule to do that. Urea cycling and the medullary osmotic gradient. Urea helps form this medullary gradient as well. It enters the filtrate, helps to form a gradient, and then gets disposed of. A diuretic is any chemical that enhances urinary output. So an ADH inhibitor like alcohol, sodium reabsorption inhibitors such as caffeine, or drugs for hypertension or edema. Loop diuretics inhibit medullary gradient formation, and osmotic diuretics is when substances are not reabsorbed, so water remains in the urine. So for example, in a diabetic patient, a high glucose concentration pulls water from the body. Urinalysis is urine is examined for signs of disease, and it can also be used to test for illegal substances. You'll be going over a urinalysis in your Lapster lab, and assessing renal function requires both blood and urine examination. So the example is renal function can be assessed by measuring the nitrogenous waste in the blood only, and to determine renal clearance, both blood and urine are required. Renal clearance is the volume of the plasma kidneys can clear of a particular substance in a given time. It helps to determine glomerular filtration rate to help to detect if there's any damage or disease in the kidneys. This is how to calculate renal clearance, which you will not need to know. Chronic renal disease is when the glomerular filtration rate is less than 60 milliliters per minute for at least 3 months. It's seen in diabetes patients, hypertension. Filtrate formation decreases, nitrogenous waste can accumulate in the blood, causing an acidic pH. Renal failure is defined as an extremely low glomerular filtration rate. It causes uremia, which is an ionic and hormonal imbalance, metabolic abnormality, toxic molecule accumulation, where the symptoms can be fatigue, anorexia, nausea, mental changes, cramps. So the treatments for renal failure is a hemodialysis machine hooked up 3 times a week, or a transplant. So then the chemical composition of urine is mostly water, 5% solutes. Nitrogenous waste in urine are urea from the amino acid breakdown. This is the largest solute component. Uric acid from nucleic acid metabolism, and creatinine, which is the metabolite of creatinine phosphate. So here are some substances found in urine. Here are some abnormal urinary constituents if glucose is found in the urine, proteins, ketone bodies, hemoglobin, bile, erythrocytes, red blood cells, or leukocytes. These are all things that normally should not be in the urine because they can't get through that first glomerular filtration membrane in the glomerulus. Some physical characteristics of urine is clear, pale to deep yellow. There could be an abnormal color that could be caused by certain foods, bile, pigments, blood, and drugs. The pale to deep yellow color comes from urochrome, which is a pigment from hemoglobin breakdown. Odor of urine, you can read through that. The disease may slightly alter the odor of a urine. So patients with diabetes may have an acetone smell to their urine. Then the pH of the urine is slightly acidic, It could be caused from a more acidic diet, or an alkaline diet could change. Specific gravity of urine is equal to the volume of water. And then the transport, storage, and elimination of urine. I think I'm going to skip this part because this talks a lot about more of the anatomy. So I'll let you guys review that. And that is the end of this chapter. So thanks for listening, guys, if you made it this far.